till I pick me for the very first time. It's darkest before the sunrise. That's when I never rain in the desert till I pick me for the very first time. It's darkest before the sunrise. That's when I super blue, super blue, super blue, super blue. I deserve congratulations.
All right. Can everyone hear me okay? Yes, awesome. All right. Thank you so much for joining us tonight. My name is Marissa. I'm one of the co-founders of Beaming Health. We're trying to build a better world for the autism community. I'm going to start with just a couple minutes about Beaming Health, introduce Rashelle, and then get to what we're here for, which is just Rashelle's wonderful advice on all things nutrition and autism. Perfect. So Beaming Health, we're building a better world for the autism community. We're doing that primarily in 3 ways. The first is we make it really easy for families to find whatever it is they might be looking for, whether it's the best speech therapist covered by your insurance in your neighborhood. We have parent reviews and more to help you make sure you're making the best decision for your family. We also have camps, special education advocates, you name it, and all in this easy search feature at beaminghealth.com, all free for families. We also have an amazing parent and professional community where parents can ask any kinds of questions like the ones you're asking here tonight to Rashelle and other experts that are part of this community and to other families in your area. And last but certainly not least, our incredible learning center, which has expert generated content on a range of topics, including nutrition and diet. So be sure to check it out. We'll send more info after this. And without further ado, I'm excited to introduce Rashelle Berry. Rashelle is the nutrition expert at Marcus Center in Atlanta and associated with Children's Healthcare of Atlanta as well. She is the person that came up again and again when I asked people, who would you go to talk about nutrition and autism? And just families love her, professionals love her, and we're so lucky to have her here tonight to answer a number of questions. I'll start off by asking some pre-prepared questions that I've seen and heard from a lot of different families, and then we'll jump into live Q&A and we can ask Rashelle any questions that are on your mind. So be thinking about those as we get started. First, Rashelle, thank you again for being here. As many of us know, autistic children are 14 times more likely to have atypical eating habits. Would love if you could talk about some of the most common eating behaviors that you've seen in your work with autistic children.
Okay, great. Well, first of all, Marissa, thank you for the very kind introduction. So really the most common behaviors that we find in autistic children is really this insistence on sameness that is part of much of their daily lives in other aspects as well, and it extends into food. So this insistence on sameness might include having the same foods each day, having certain foods in certain locations. For example, they might eat the pizza at school and the chicken that grandma eats, but if mom or dad try to make the chicken, they won't eat that. And with foods that are not on this repertoire that the children want to eat, they might have some extreme behaviors that go a little bit beyond what we would consider from a picky eater. A picky eater might just say, no, I don't want to eat broccoli, but you could put some on their plate and that wouldn't be a big deal. For autistic children, we're going to see things more like gagging, yelling, screaming, running away from the table, maybe refusing to sit with other family members during their meals because they don't want to see the food that they don't want to eat. They might not want to smell the food that they want to eat. We also see a lot of leaving out full food groups. So it could be that they truly do not eat any fruits and vegetables, and it's not even like a few get snuck in along the way. But really, I think the biggest things are this insistence on sameness and how that extends into different areas of eating. The other thing I will say is that there is, for some children, there's a propensity to have a little bit of an obsession with food. The way that someone might have an upset that a child with autism might have an obsession with Thomas the Tank Engine or whatever. There's also like an obsession with going to McDonald's over and over, going to, eating Cheetos or whatever. And when those foods are more calorically dense and foods we would consider less healthy, there is an increased incidence of overweight and obesity in this population. And some of those also, and I'm going off on a tangent, might be related to some medications as well. But I'd say those are the top atypical eating habits that I see on a regular basis in my clinic.
Got it. That's super helpful. And that's super consistent. I know for my own family with my brother, there was things around smells and around texture, and it was less of like he just didn't want things. So totally.
Yeah, eating and cooking are very large sensory experiences. If I'm cooking sweet potatoes in the oven, anyone who's walking into my house is going to have that whiff. Yeah, even one time had a friend's son, family over, and the son definitely has some sensory stuff going on, I should say. And I happened to be making sweet potatoes, which is why I just thought of this. And he walked in and he literally started gagging in my house. And I thought, and of course, my friend was very apologetic, but I was like, remember, this is what I do all day. It's all good. I know I'm not making rotten sweet potatoes, but it feels differently. It's a big experience, something that we might not, it might not feel like a big experience to us.
Totally. Next here, along with some of the challenges with just eating preferences and patterns, just autistic children are more likely to have gastro issues, as you well know, such as stomach pain, discomfort. How would someone know if their child has some of these issues, and what advice would you have for them?
Okay, so children with autism, autistic children are more likely to have kind of unidentified stomach pain or something that we can't figure out exactly what it's from. And a lot of that is related to a much higher incidence of constipation. The constipation comes from a variety of reasons. One of the reasons is withholding, is really behavioral, is that the child doesn't want to go to the bathroom because it might be an unpleasant feeling. So they consistently might clench so that they are delaying going to the bathroom. And then their stool becomes more and more dry, and this process of constipation kind of continues. The ways you would know and then the other reason is due to diet. I mean, some people are just constipated because they're constipated, but another strong reason is diet, is this lack of fruits and vegetables and fiber, and a lot of kind of white starchy things that can back some people up. Some things that I like to note is constipation is not only not going to the bathroom every day. So looking for things like hard stools, obviously skipping a lot of days of going to the bathroom. I talk about poop all day long, so hopefully no one's offended by the rest of this conversation, but kind of a smellier poop that feels off, like not like normal poop smell. A hard stomach, also frequently clogging the toilet, and making sure that it's not due to just not knowing how much toilet paper to put in the toilet. But a dry stool is going to more frequently clog a toilet. Another thing is leakage. So if a child has constipation that's really lasted for a long time, they might get something called enteroparesis, where there's a massive stool and then the rest of the liquid stool kind of goes around that mass. And so it appears that the child's having constant accidents, but they're actually not getting rid of all of their stool. in their colon and their rectum. So again, the number one GI issue in autistic children is going to be constipation. And so working with a GI doctor who is specifically trained in this, and just being also loud at the pediatrician's office and making sure that the doctor feels your child's stomach and feels for stool. And if you're and going in that direction, and there are different medications and different other things that one can do to alleviate constipation. So that's it for kind of the poop side. And then that also just can cause some generalized stomach pain. The other thing that we see is a different presentation than we would expect for something like gastroesophageal reflux or GERD or just general heartburn, as it's called. And that might include not wanting to lie down or really crying if a child's less verbal, when they lie down, maybe becoming upset each time, actually vomiting when, it's not normal to vomit all the time if you're not sick. So if you're seeing a lot of vomiting, then of course that would be something to look into. Maybe doing some weird posturing. Like, think about it, we've all experienced heartburn at one time or another. So if you're having some heartburn, what might, some of these things that we wouldn't think of, but it's like some weird movement, things like this. And then also just having a kind of low disposition. Like I'll say to a lot of families, does your child seem like they feel well most of the time? Or are they lying around and seeming uncomfortable? Mm-hmm. So my recommendation is, one, knowing those signs of constipation, like I told you, and you can easily look those up as well, and making sure you know exactly what constipation is, and that even if your child's going some every day, they might be constipated, and that definitely, like, number one contributor of stomach pain. Mm-hmm. And then secondly, that the reflux. I will say that in the clinic that I work in, we treat children with feeding difficulties. Obviously, it'd be hard to work at an autism center and then not treat children with feeding difficulties. But we make sure that we ask a lot of questions to rule out that there are any organic concerns that could be leading to a child favoring one food or another. So although this isn't GI, also, I would just think about general allergies. If you're a generally allergic family, have a lot of asthma, eczema, or if maybe the child was little and was previously eating foods, or there's been rashes, things like that, I would make sure you're pushing deeper with your doctor and determining, is there anything that could be causing this child pain who is not necessarily able to communicate as well as others.
That's super, Rashelle. And others in the audience too, feel free to chime in if stuff's coming up. And so when you say organic concerns, you meant things like allergies?
Right. So I mean like true medical pathology concerns. So a medical reason that a child would not feel well.
Yep. Yeah, that makes sense. And I loved those flags you called out, just to summarize what you were sharing earlier. So things like skipping the bathroom, smelling your poop if the toilet's clogging, if there's a hard stomach, and making sure to bring it up with your pediatrician is all super helpful. My favorite thing you said was just, does the child feel well? It's like a really great question. And everybody poops. So yeah, this is, don't be shy about that stuff here. Next, you alluded to this a bit in your answer to the first question, but just knowing that difference between when it's someone being a picky eater. I know I didn't like it when my mom made me eat my Brussels sprouts back in the day, but what's the difference between that and more selective eating?
Absolutely. So pickiness, I think the biggest difference are the behaviors surrounding being offered a food or asked to eat a food. So if a child's picky, they're likely not going to vomit at the table if they don't like the food. They're likely not going to elope, run away from the table. They're not going to scream and cry and do all of these really large behaviors because it's just food. And they might argue with their parents. They might go back and forth, and they might kind of come to a conclusion of what they're willing to eat and what they're not. You're not going to see some of those larger behaviors. Also, general pickiness doesn't cause you really to worry too greatly about your child's health, whether it be growth or nutritional deficiencies, whereas selective eating in autism does cause us to have those concerns. I also like to think about what foods is the child eating. So in pickiness, they might have like 1 or 2 fruits they'll eat, maybe maybe cucumber, like some easy vegetable, number of starches, number of proteins, but you can pretty much find food in every single food group, or you could work with that child decently easily to make sure they had at least 1 or 2 foods from every food group. With selective eating and autism, we're going to see absolutely no fruit, absolutely no vegetables, not even close. And the parent, the clinician, is going to be more concerned about nutritional deficiencies. So there's this kind of heightened state that there might be a medical consequence or a nutritional consequence of the child not eating a wide variety of food.
That's so helpful, Rashelle. And I'll share a brief story too. I know it's so hard for parents to know the difference, my own parents included. I'll never forget, my brother was about 10 or so, and he said to my parents, I can't have another bite of these veggies, I'm going to throw up. And they're like, no, Chris, you have to eat your vegetables. And lo and behold, he took a bite, and there we had it. So yeah. No.
Right. Big reaction, something you wouldn't expect and a parent wouldn't expect.
Exactly.
And one more thing, it goes against all the rules that we kind of all know about eating and parenting around food. I think that is one of the things that really strikes me when I work with families, is they're like, but I did the same thing that I did with my older kids, and yeah, they don't like everything. So it goes against our general senses about how to introduce food to children.
Mm-hmm. Definitely. Awesome. This is a great topic. So
favorite question.
Yes. So I'm sure everyone on here too, we hear a lot about, should I put my child on gluten-free, dairy-free, calcium-free, keto, you name it, all kinds of different diets out there. Would be really curious to get your thoughts on all of these.
Okay. So first of all, I go by the general thought that all children are different, all humans are different, and all autistic children are different. So it doesn't make sense to me as a clinician that every child would benefit from one specific diet, because they're all really unique. So first part, the body of research out there that has looked at specifically the gluten-free, casein-free diet does not find on a population level that the gluten-free, casein-free diet is prescriptive in increasing vocalizations or socialization. It doesn't have that therapeutic effect. That has not been found over and over and over in really well-designed clinical trials, I would say. That said, there are a subset of children, as they were going through these studies, that did seem to probably feel better and probably be more willing to participate in the tasks, educational tasks or whatever it might be. And so those children likely had some sort of either sensitivity or allergy or intolerance. So overall, as a rule, I would say do not start eliminating foods willy-nilly from your child's diet, because the worry would be that if you wanted to then put them back into the diet, they wouldn't accept it, because again, going back to the selectivity and autism. But if you have a suspicion that there are certain foods causing concerns for your child, I would really be insistent in bringing those up to your pediatrician and determining if there are any tests that you would want to run, whether it be going and speaking with an allergist, going and speaking to a GI doctor, or like if your child's having a lot of diarrhea and they love milk, it would be very reasonable to do a test where you try lactose-free milk or something like this. So I would say overall, it's not a diet I recommend. Rather, I like to look at the specific child and see, is there something we are missing where they could be feeling better, be more open to eating new foods, and if you don't feel well, you really don't want to participate with the world very much, be more willing to participate in things that potentially they are. The keto diet is a really difficult diet. I just want to say that. That's a very difficult diet for a child, I would say, any child, no matter what food selectivity they might or might not have. So I would beware with that one.
Yeah, no, I resonate with all of this so much. I know if my stomach's not right, nothing is right. It's so hard to do anything. And I love what you're saying here, where honestly, changes in diet are good for so many different kind of people, not related to autism. So it might be more just a medical something. Love it. All right. So, love this question. So when should someone seek out a professional, like you're talking about, a GI doctor?
Yeah. So full knowledge here is that there unfortunately are only but so many professionals who are experts in this, which I think is much of the impetus for why Marissa does the work that she does, is that it's really hard to find clinicians, doctors, GI doctors, allergists, dietitians, etc., who are specifically trained to work with autistic children and to think outside of the box in a different way than they potentially were trained to. So the biggest things I would say is you're going to start with your pediatrician. That's your main point of contact. That's your medical home, if you will. And I would be ready to talk about all these things that example from this lecture. There's some other materials on Beaming Health right now. And I would be insistent on saying, like, do I need to go to a GI doctor? Do I need to go to an allergist? I know that this is problematic. Do I need to see a behavioral psychologist or a BCBA or get a speech pathology assessment to determine, kind of let me know, is this behavior kind of going into this realm of atypical? Because one of those professionals is going to have a good idea of, are you seeing kind of more typical behavior that it's problematic, but we don't need to treat it, or is this something that we need to treat? And if I was going to someone, I would ask them, have you worked with children with autism? Do you, what do you do differently? For example, I've seen children who have gone to other dietitians who aren't used to working with autistic children, and they will be like, you need to eat this, this, and this, and this. And then they come to me and they say, there was no way they were going to eat those foods. They didn't even ask. They just had like a prescriptive diet they were giving me. So I would make sure you're going to someone who understands the behavioral issues around eating that might be coming up.
That's great advice. All right. So without further ado, we are going to open it up to questions from anyone in the audience. You have a couple options here. You're welcome to raise your hand by clicking on the hand icon at the bottom of your screen, or you can write directly in the chat. And for anyone who wasn't on while we're waiting for questions from folks. We are so excited to be expanding. So Beaming Health right now is live in 7 states. We're growing all the time, expanding and adding to other states. So if you or anyone you know around the US is looking for autism services, Beaming Health, again, is a free resource for families to find great care options, camps, you name it, in their area, and great content developed by clinicians like Rashelle and our parent community too, of course. So is anyone looking to ask a question? I know, oh, here we go. Awesome, great. First question here from Leslie, who has a student who will gag when he touches certain foods.
Absolutely. I think that comes back to that, like the child that doesn't even want to sit with the family because they're more offended by the smells and things. My recommendation for something like that, you didn't really ask this question, but I think this is where you're going. My recommendation would be, if there's a food that's hard for the child to touch, maybe start with a very, very small amount. And it's a food that, and part of maybe the child's IEP or whatever is to be working on new foods. I would start with a really, really small amount, something that doesn't even seem like food, almost like a rice size or like a tip of a fingernail. And I would make sure that you're not trying like one food one day, one food another day. Just focus on trying that one same food over and over. It's kind of like exposure therapy. You get, suddenly it's like, okay, this is the same thing every day. It doesn't feel so gaggy to me. And lowering the demands, if you will, like the ask. The ask is like, here, can you just touch this piece of rice? And can you do that for 5 days? And I'm not going to ask you anything more. Like, it's not, the reward for doing it is not that I'm going to give you more. That's actually punishment, right? So yeah, that's a very common issue. And then I think those 2 things that I said, really bringing down the volume, the size, and then making sure it's just the same thing over and over. So it's not like every day there's a new food that needs to be touched.
That's awesome. Really great advice. Nicole, we're coming over.
Of course, it was a single grain of rice. Of course, I used the one example that he gagged.
Oh, no.
Maybe we need to try a new food.
Oh, no. Awesome. Nicole's asking, would a reward system work?
Yeah, absolutely. In general, the psychologists I work with have said this before, and I think it really sticks with me when I am giving advice. The biggest thing that the child wants is for everyone just to leave them alone and stop presenting food. So the best reward for doing whatever the ask is, whether it be touching the food or taking a very small bite of the food or licking it, is that then they get a break for like 30 seconds or a minute, and you're like, good job, now you get a break. It could be that you need a more powerful motivator than that, getting to play with a toy or something like that. But that break is something that's really important. That goes back to that earlier thing I said, the way that, we don't want to reward, you ate a grape, now I'm going to give you 5. It's, you gave a grape, awesome, that's all I needed you to do today. So the child learns, like, that was all I had to do, and now everyone is letting me do my thing. But yes, rewards can be very helpful. We don't typically use food as rewards, because then you can just get into a bad cycle, or the child can become over full from the food reward. But I do know that some practitioners use that.
Really great question. One that I had while we're waiting for any others was just what's sort of behind that, like when a child touches a food and it prompts a gag response, what is going on there for the child?
It's probably just that large sensory response, and For children who are food selective, who are autistic or not, honestly, the way that I kind of see it is they see the foods they eat as food, and they see all the other not as food. So it's the way that we don't see bugs as food. And if we had to lick a bug, we might get gaggy, depending on how high of a sensory response it is. But to them, that food feels very offensive in a way that is not typical, likely related to some of the sensory characteristics, and then likely related to just not thinking that's a food.
Mm-hmm. Got it. No, it's super helpful. From Sandra here, I tried introducing new foods, but my son won't taste it first. He smells it and then he'll determine if he'll eat it or not.
Yeah, and that's just him checking it out. I'm not, I don't know other details about your son, but it could be that you look at what he's eating and you see what might be a like food to try. That is called food chaining, if you wanted to look it up. If you see, for example, that your child likes drier foods or crunchier foods, you might approach foods that have similar characteristics. Sometimes with the kids I'm seeing, if we're trying to identify a new food to work on, and particularly like a new nutritionally relevant food. So it could be that the child eats, all forms of potatoes. And while it might feel like, oh, let's get him to eat a different French fry, I'm not really sure what that's going to do for his diet, but it could be that we can try like a sweet potato fry and start getting closer to a vegetable, something like this. So those would be the foods that I would try to focus on. Also, getting back to that kind of sensory experience with smells, cooked vegetables and really cooked food in general can have a much more offensive smell than raw food. Oftentimes, actually, with patients who are on chemotherapy who are having a lot of difficulty with eating, the recommendations are to not present cooked foods because that smell can bring up that gag before one even tastes it. So it could be that you find that using raw foods, cold foods that have less of a smell will be more acceptable.
Mm-hmm. Something you started to allude to was exactly the question that came to mind for me, is just food selection.
Mm-hmm.
I'm just curious if there is sort of a guiding principle. I'm sure it's something around nutrition, but just if you have more thoughts.
Yeah. So of course, my bias, I'm a nutritionist, so I want feeding therapy or selecting new foods to be nutritionally relevant. Like I said, if the child will already eat 5 different types of breads, waffles, and pancakes, I just don't think if we're going to work on a new food, we need to work on another slice of bread because there's some decent variety and you're already getting all the nutrients that one would find in bread. So going through each food group, and if your child is able to let you know and is able to provide some choice, then I would pick some foods that seem like they'll be easier. I mean, we all eat food, like I know if there's a child, I'm not going to necessarily recommend cooked spinach to start. So picking foods that we know are a little easier, like apple slices or cut grapes, something like that.
Totally. That makes sense. Another great question here from Jennifer. Can you talk a bit more about supplements and foods that are autism and bipolar brain friendly?
Okay. I don't know as much about bipolar brain friendly. So full disclosure, I don't have that level of knowledge. There have been some studies out there on omega-3 fatty acids and autism and ADHD. I would say that the data is not like super convincing, but it also, there's no harm in it. And I think omega-3s are, if your child would take it, are reasonable. Of course, if you can get them to eat things like salmon, wonderful, but that might be a bridge too far. In general, I really only recommend supplements if I think there are holes in the diet. There aren't broad supplements that I'm recommending on a daily basis. Part of the reason is also that if a child's diet is really tipped towards one or two food groups, I want to be very careful that I'm not then over supplementing and that they're getting too much of any given nutrient. So I do it more specifically based on the diet versus just giving a all over one. With respect to bipolar, there might be I might have read some data out there on B12, specifically with depression, but I want you to not quote me on that and do your own research on that. But that is something that I believe I was just reading something on. I don't know if it's specifically for bipolar, but it was for depression.
That's super helpful and makes a lot of sense what you were talking about with supplements. Are there specific holes that you see often, or certain supplements or holes that you see more than others?
Yeah, so if a child really does not eat any fruits and vegetables and doesn't typically drink juice, it sounds crazy, but I end up seeing scurvy way more than one would think. And that's vitamin C deficiency that we think about with pirates and sailors and things like this because they didn't have access to fresh fruits and vegetables. The thing about vitamin C deficiency or scurvy is that it can develop more quickly than other nutritional deficiencies can. So some nutritional deficiencies, it would take a while. Like your body has really good compensating mechanisms so that we're not going to see a nutritional deficiency syndrome. Vitamin C is not like that. So if your child really is not eating any fruits or vegetables or any fortified foods like a fortified cereal, by the way, fortified cereals are wonderful. If your child is willing to eat cereal and you're worried about their vitamins and minerals, fortified cereals, if you can get a cup or two a day, and then you can feel pretty good about your child's diet. So that comes up. Rickets, which is vitamin D deficiency, also comes up, and this might be from lack of having milk, but also it could be because the child isn't playing outside as much. Maybe, they're just not running around the neighborhood, or they're inside more interested in screens, so not getting that vitamin D that you would get from the sunshine. The other one that we see is iron deficiency anemia. Likely it is, I actually become more suspicious that a child is going to have iron deficiency if they are drinking a lot of milk. So if a child is getting, or an adult by that matter, is getting more than 3 cups of milk per day, the calcium in the milk blocks the absorption of iron, or can block the absorption of iron. So then what can happen is, even in the presence of eating foods that contain iron, such as meats, beans, dark leafy vegetables, things like that, there can still be a concern for iron deficiency. And I believe it's the American Academy of Pediatrics recommends that all children who are drinking more than 3 cups of milk per day should be checked for iron levels. So those are, I think, probably the top 3 that I see.
Oh, that's super helpful. Very interesting. I wouldn't have thought about that last one, especially.
Yeah.
Are there any other, while we're waiting for other questions, are there any things that you sort of common questions we haven't touched on? Oh, I spoke too soon. So Jennifer followed up and said she eats everything, which is great. She just craves sugar and junk, and we try to keep her gluten and dairy free, but wonder if there are foods we should definitely stay away from that will worsen agitation or anxiety or rumination.
Yeah. So is the question more, do you think she's eating more sugar and junkier foods as opposed to eating the variety of foods? So even though she's willing to eat a lot of foods, is there more of a preference to eat the sugar and junk? I don't know if you can answer that in the chat. That will help me.
Yeah. Yes.
Okay.
Exclamation point. Yes.
So, I didn't even mention this. This grazing and kind of eating sugar and junk throughout the day is a big issue. And then the big behavior surrounding limiting grazing or that snacking during the day. what I would do is start with a few things. So one, set up a schedule that maybe you even write down the same way, like in a school that they write down the schedule so that children know what to expect from time to time. You can write out that schedule, like 9 a.m. is breakfast, 12 p.m., et cetera, et cetera. And then I would start increasing the time that your child does not have access to food so they get onto a more regular snack and meal schedule. And I would do that really, really gradually. So it could be that you start with, a lot of times the afternoon's a big issue because maybe the child hasn't had as much to eat when they're at school, maybe due to food selectivity, maybe due to a 15-minute meal time. I mean, who knows? And so they're hungry and they're trying to get all those foods that they really love all afternoon. And then here it's dinner time and they're not hungry at all. But a meltdown ensues if you say, no, you can't have food. So what you might do is start with 15 minutes before dinner, you make it clear, no food. Do that for a few days and maybe even set a timer so it's quite clear, we're waiting 15 minutes and then we're going to have dinner. And then after 3 or 4 days, when your child's gotten used to that, increase it to 30 minutes. So this is just called fading. It's a very common behavioral practice. And you're going to slowly increase it so you get to the point where your child's eating closer to every 2 to 3 hours, which is what we all do. We probably all eat about every 3 hours or so. That's when we start getting a little hungry. Maybe we need a snack. Maybe we're getting a meal. Because it sounds like your child likes a lot of different foods, just really prefers her favorite foods. And so this way, then your child will be more hungry for those foods and not feel this kind of desperate need to be eating. It could be that she's worried, she likes snacking because she is worried about when she's going to have access to this. So if you're just very clear with those rules and slowly increase it so it just becomes a habit. I tell parents a lot of times at school, children understand when's mealtime and when's snack time. They really do have that ability to learn it and understand the rules. So it's just creating some similar rules at home in a very slow way that feels manageable to the child and to the parent.
Mm-hmm. And I just wanted to rewind back to when you start something like fading, what you just described, what is sort of a time block you think is reasonable to start with? I might have missed something.
I would say between 5 to 15 minutes, and you would go as slow as your child needs. And I would increase every 3 days with calm behaviors. So if for the first day, they're crying the full 5 minutes, second day, crying for half the time, third day, not crying at all, have 2 more no crying days, and then go to 10 minutes.
Got it.
And then you might be able to increase even more because there's a very understood rule. Like I said, then there's kind of that reward. The reward is it's dinner time, or the reward is it's access to a snack time. And so they might start getting that system, and then you can go a little more quickly. Fading works with a lot of different things. Another thing that I often see is children who don't want to drink any water and only want to drink juice. And so we'll do the same thing with fading for juice, where we might do 7 ounces of juice with 1 ounce of water. After 3 days of the child accepting it, 6 ounces, 2 ounces, et cetera, But you're going to go for about 3 days of no behaviors, and then you can move to the next step.
I love that advice. And one part of Jennifer's question I wanted to make sure is just, are there any foods that you think are just really should be avoided, or is it really no specific foods just based on your head shake? Yeah.
I also don't want to, like all of us, if we're told we can't have a food, then that's the food.
The forbidden
So you don't want to create like an obsession with
quite literally the forbidden fruit, maybe.
Yeah.
Leslie, great question here. My student is interested in others' foods, but when we present the food to him, he will push it away. Is there a reason why he will tolerate others eating the foods, but will avoid it when it's given to him? He is 3.
Okay, so he probably just feels very safe that if it's on someone else's plate, he's not going to have to eat it. But if you are working on trying new foods, that's a great place to start, is ones that he's already showing some interest in. And then I would go back to what we discussed earlier, which is just presenting a very, very small amount of it. One thing that I use when I describe this is like mayonnaise. I don't know. I mean, I don't know of anyone that wants to eat a full spoonful of mayonnaise, but if you tip dip it, I mean, I could lick a small tip dip, like if I just dip the spoon. So same thing, if the child's showing interest, say another kid's eating pasta or something like that, maybe don't present the whole thing of pasta, because that feels overwhelming. And the child's going to look at that pasta and think, oh, they're expecting me to eat all of that. Rather, just put like one noodle on there or half a noodle and try slowly. So go with what that child is letting you know they're interested in, but then bring it down so that they so that they can maybe be more likely to trial it.
Mm-hmm.
And I'm telling you all of these things, and they're kind of some of the basics that we do at my program, but I'm also acknowledging that if it were this easy and I could just tell you these little tips, we wouldn't have this big, we wouldn't have all these feeding therapists that are specifically dealing with children. So if things like this don't work and your child still has really big behaviors, you really need feeding therapy. It's going to be hard to just take some tips and make it work. Like I started with, what really defines this is those large behaviors. And so that's when I would be seeking out a feeding therapist who's specifically trained in working with autistic children.
That's really good advice. It's not easy as 1, 2, 3.
No. Like I said, these are just some tips, but if the tips aren't working, you need some professional help.
Yeah, totally.
And anyone tells you they can magically fix it, no. I would steer clear.
Awesome. These questions have been great. If anyone has any more questions, definitely send them through. Rashelle, are there, great question here from Amy. What actually does a feeding therapist do?
Okay.
And also, just what would that look like? Is it typically in a set? Where would the therapy happen? What happens during therapy? Yeah.
So there are a number of different professionals and clinicians that provide different types of feeding therapy. So speech language pathologists and occupational therapists usually do a more sensory-based approach to feeding therapy. I'm going to go off on a small tangent. They also, if there are children who have true skill deficit, maybe there's some swallowing concerns or learning how to chew, that would be something that a speech pathologist or an occupational therapist would be very adept in really working on those skills as they relate to eating. It could be that a child has been avoiding certain foods and then has not gotten that strong chew because they refuse to chew anything larger than like a more chewy than a meltable solid. And they're going to do a more sensory-based approach, use some food chaining, use some, messy play, touching food to lips, things like this. And the way that it usually looks is the child goes to a session, the parent might bring a food or two that they want to work on and maybe some favorite foods. And then the therapist is going to work on getting that child more and more comfortable with the food. That's a more child-led method, and it works for some children, but for more children who are more firm in their selective beliefs, it might not be enough for them. And so behavioral psychologists or BCBAs are also going to do feeding therapy, and that's going to be more with an ABA approach. And that is going to be more of a lot of the things that I've described is bringing down that demand of food, fading, providing reward, providing breaks, I would say, I've worked with psychologists for many, many years. If there's a psychologist that is going in a little too, is not using fading, I would look for someone who is going to lower the demand greatly so that the child becomes more comfortable. Feeding therapy should not just be a screaming event. It should be something that the child can achieve. But so behavioral psychologist is going to be really similar as well. To bring in food, or they're going to provide some food, and then they're going to present it at certain intervals. And then the child will get a break or a reward for completing the task. The task might even be just putting an empty spoon in their mouth to start, and then slowly increasing the amount of food and figuring out what reward system is going to work for that child.
Mm-hmm. And is that typically, if you have a preference of in-home and clinic, doesn't really matter?
It doesn't really matter. We were talking right before this event about working telehealth. Our practitioners did try telehealth at the beginning of the pandemic, and that was a lot harder for children who had a higher degree of food selectivity, because it was just too much. It was too much like home. But I would say if a therapist goes into the home or in a clinic, sometimes in the home's good because you really get to see what's going on. All the aspects, like does the child come to the table, things like this.
Mm-hmm. Totally. In our last few minutes here, Rashelle, are there any kind of is there any parting wisdom you would share with everyone?
I think the biggest things I would share of what I've learned through the years is one, always advocate for your child, which I'm sure many of you know, and that if something feels off, just, like I said, like if you feel like your child doesn't feel well, if you feel like they're having a response to a food that is atypical or abnormal, if they're growing well and the pediatrician keeps saying they're growing well, but they're only eating 3 foods, keep saying that loudly and really push to get help. I see many families who have been trying to say over and over they want services, and what they keep hearing is your child is growing very well, you have nothing to worry about. And then the parent knew, and by the time they come to us, they're like, I'm so glad I know someone, I'm seeing someone who understands. So now that and we've had this conversation about feeding therapy, feeding difficulties, GI concerns, you have that knowledge to be able to talk to medical professionals and really advocate for the services that your child needs. And then the second, I think I said this already, is really asking people, have they worked with children with autism? That's an important thing to know. There's a different way that you have to practice, and so you would want to make sure, it's the same way that some women like going to women gynecologists or things like that. You might just have a preference, and you're going to ask if that person's worked with autistic children.
Totally. Awesome. Well, thank you so much, everyone, for joining. If anyone has any last minute questions here, feel free to throw them in, but if not, we'll let everyone go. I know it's getting late there on the East Coast. And Rashelle, thank you so much for doing with us. I learned so much. This was so helpful and tactical and just useful. So thank you for all the work you do with families and for your time tonight. We really appreciate it. Great question here from Sandra. Perfect. Way to close this out, Sandra. I don't know if you can help me. My son is 10 and still on a bottle. Therapists in school have been trying to help him, but no progress. Any advice on where to go or see for additional help? I would love for him to learn how to use a straw, but doesn't know how to suck on it.
Okay. What area of the country are you in?
I'll wait for her to respond. Brookfield, Illinois.
Illinois, okay. And I'm going to ask another question. What's in the bottle and how much does your son have of that every day?
full bottle of water.
Okay, so just drinking water. So it sounds like there's a skill deficit or yeah, a skill deficit, maybe not knowing how to use a straw. I would start with a speech pathologist, and really working with him to work on those muscles that are involved with drinking from a straw. It's a different, pursing your lips is a different thing. And I know the speech pathologists I've worked with have been they're really creative in the way that they get children to learn how to drink from straws or drink from more age typical vessels. For example, they'll cut straws really, really little so you don't have to suck it all up. They'll do the thing that we've all done when we were young, where you put your finger on top, but they have a lot of therapeutic tools to train children how to use their muscles differently than they've used before. So that's what I would start with, seeking out a speech pathologist who specifically works on things like that. And again, I would ask those questions. Have you worked with children with autism? And if you specifically worked on this issue, it's not the most rare issue. There are a lot of children that are still on bottles. So I would think and hope that there's that they've seen a child like your son before.
Awesome. Great question. All right. I know, yeah, that was great advice, Rashelle. And Sandra, thank you for the question. I know we have a couple minutes here. If anyone has any last minute questions, we'll try to cover them, but let's see. Yeah, all right. Well, with that, this conversation doesn't stop here. We have a community on our site. Again, it's free. It has families, professionals across the country that are asking questions and getting responses just like this. It's just beaminghealth.com, and you can create a free account using your Google login or your Facebook login. We try to make it as easy as possible, and you can post anonymously or share as much as you like with anyone there. So we look forward to continuing interacting with all of you and helping you in any way we can. Thank you so much for joining tonight.
Thank you.
Cool.